Thank you for allowing us to speak today on this topic of what makes a useful biomarker of disease, implications on RNA and extracellular vesicle-based biomarkers. I'd like to credit the co-author of this talk, Dr. Venkatesh Murthy, who's at University of Michigan, Ann Arbor. Neither of us have disclosures specifically related to the content of this presentation. What are the characteristics of an RNA or EV-based biomarker? First, the analytical performance. Can the assay measure the RNA or cargo within the EV, whether it be proteomic, metabolomic, with high reproducibility, that is precision, and correctly to the true value, that is accuracy? We also consider things such as assay throughput and validation of specific biomarkers across a broad disease spectrum in different diseases. How well do these biomarkers perform? In this context, there are sources of what is called pre-analytical variability. That is factors that are actually affecting the analytical performance or the performance of our assay that occur during collection or before the actual assay is performed. For example, how soon after the collection of plasma should EVs or RNA be isolated? What are the conditions for ideal sample storage and how do they affect the precision of the measurement? Is there a preferred method or kit for RNA isolation or EV isolation? And are there issues around the limit of detection for low abundance RNAs that might impact the development of these biomarker assays and their subsequent validation? I should mention that on every slide, there are references at the bottom, which are highly recommended. One of the references that I find especially useful in thinking about this topic is by Dr. Holland, entitled "What Makes a Good Biomarker?", which is published in Advances in Precision Medicine in 2016. I have another article here by Dr. Vasan, who is a leader of the Framingham Heart Study, published in Circulation in 2006, both of which are recommended for the topic. Going on, we also think about clinical performance, and are these biomarkers for diagnosis or for prognosis? For diagnosis, we think about the ability of a given biomarker to rule out or rule in the disease. To rule out the disease, we call that property sensitivity, and how specific the assay is for the disease, we term specificity, and we'll go into these topics a little bit more specifically later. For prognosis, how closely related is the assay to the outcome, independent of what we know about this individual otherwise? So things such as the age of the individual, the sex of the individual, things like blood pressure for cardiovascular disease. How does our assay add to that? And can this assay and its result tell us who might develop the outcome over time? We think about concepts such as discrimination and reclassification, which we'll discuss briefly. And does the model based on this biomarker level predicted risk, does a predicted risk from that model match what we observe when we follow individuals over time in terms of the event of interest? So what are the phases of biomarker validation? The term biomarker validation has quite a few different aspects. This figure is taken from the NINDS website that you can see there. Biomarker validation occurs over several different phases: discovery, analytical validation, clinical validation, and then what is called biomarker qualification. Our discussion is going to essentially focus around analytical and clinical validation, specifically after a given biomarker is discovered. In terms of the assay, what is its precision, sensitivity, accuracy, the range, reproducibility? And how can we then move those assays into validation, into clinical studies to tell us more about who will develop a given outcome? So let's start with sensitivity and specificity. The specificity of a given test is the probability the test is negative, given that the patient does not have the disease. In simpler terms, this is also termed the true negative rate. Tests with high specificity are those used to confirm a given diagnosis, rule it in. What you see here is the definition of specificity, which is the ratio of the number of true negatives to the total number of individuals without the disease in the population. The sensitivity is the probability that the test is positive given that a patient has the disease. In this case, tests that are highly sensitive are used for screening or to rule out the disease. This is also termed the true positive rate. Again, you can see the formula here taken from this website below that defines the sensitivity as the number of true positives divided by the total number of individuals with the disease in a population. Let's conceptualize this. This was a very nice graphic decision tree that's from the website that you can see here, where we look at 10,000 patients, 9,900 of whom are healthy and 100 of whom are sick, denoted by H and S and the disease status here. And a certain proportion of those individuals will test positive or negative for a given condition based on some cutoff value. And you can see here denoting those individuals who are healthy who then test positive as false positives because they are healthy without a given condition, and those individuals who are healthy and test negative as true negatives, and of course the corresponding classifications here. So looking at this chart, we can easily calculate the sensitivity and specificity, and here you see the sensitivity is a true positive rate, which is essentially the number of individuals positive over the individuals who have disease in the population. In this case, you can see that as being 90 divided by 90 plus 10, or 90%. And the specificity analogously denoted here also is 90%. Sometimes these are expressed as likelihood ratios, but we'll stick with our standard sensitivity and specificity here. How about predicted value? When you think about a given condition or given individual, you want to know how good is a given test to tell me about a given condition in this population. The prevalence of a given condition in the population has a huge bearing on how useful a test is in that population. So we think of things like positive predictive value and negative predictive value, and you can see their definitions here. In those populations where a disease is not very prevalent, in this population, the disease is not very prevalent. Only 100 individuals have this condition corresponding to 1% prevalence. You can see that the positive predictive value of this specific test is going to suffer, whereas the negative predictive value is quite good for this test in this population. So this is just to show that the predictive value of a given test really factors in another piece of information, which is how prevalent is a given condition in that population. When we think about tests, we also think about how do we define the optimal cut point for a test? Is a value greater than X the right cut point, or a value greater than Y? To do this, we borrow something initially from signal processing and radar called the receiver operating curve analysis, the ROC analysis. You can see the reference below. This is something that everybody has seen before in biomedical journals and scientific literature. The ROC curve, or receiver operator curve, represents the true positive rate versus the false positive rate for different tests. So you can see here the true positive rate, which is the sensitivity, graphed against 1 minus the specificity, or the false positive rate. Each point on this ROC curve summarizes a different cut point to call a test positive or negative. As these ROC curves move to the upper left corner, the diagnostic performance of the test is better. This diagnostic performance we refer to as discrimination. Importantly, this specific characteristic does not take into account the disease prevalence. Let's look at a real-world example from the literature. This is a manuscript published in the New England Journal of Medicine earlier this year called "A Novel Circulating MicroRNA for the Detection of Acute Myocarditis." Several different ERCC investigators are represented in this interesting work. These investigators sought to look at specific RNAs in the diagnosis of different conditions, and specifically a condition of inflammation of the heart muscle called myocarditis. What you'll see here on the left panel is the distribution of expression of this given microRNA in circulation in these different conditions. As you can see here, the differences between those individuals, the distribution of individuals who are healthy versus the distribution of this microRNA in those individuals who have the myocarditis condition is very different. Now, you can build models for each of these specific conditions and whether these specific RNA here can actually tell you and discriminate the differences between individuals with and without a given condition. So what you can see here is the ROC curve, as we discussed, for the differentiation of myocarditis versus healthy donors. And you see here a C statistic. We'll go through that in a second here. In the next slide, you can see the same ROC curve for myocarditis versus myocardial infarction. Then in comparison here on the right, you can see two different models, one built on age, sex, troponin, and ejection fraction in the green here, then another model built on that model plus the microRNA. And what you can see is that there's an improvement. The curve is moving to the upper left corner in the discrimination ability. Now, it's important to know that as you have more overlapping cases, it should make sense that the ability of a given test to tell you the difference between condition A and condition B, if there's overlap in that biomarker across the two conditions, will be reduced. The performance is less. What you can see here also is the relationship, again, of different biomarkers, now different microRNAs in circulation and these different conditions. You can see as the overlap increases, the ability of that given microRNA to tell us the differences between the conditions goes down. In general, we look at things like discrimination or C statistics alongside how related is a given biomarker to the condition of interest. So for each unit increase in a given biomarker, what is its relationship with an outcome? We term this association. This is where you hear about regression modeling, survival models that model a time to a given outcome, or logistic regression models that model a binary event, whether the individual has or does not have the outcome, or has or does not have a risk factor. Certainly in these models, the background that you're interested in, meaning what specific covariates you adjust for, are very important. This is from that work. You can see here that adjusted for sex, age, troponin, and ejection fraction, the level of this microRNA expressed, as you can see here, is strongly associated with or related to the condition of myocarditis relative to myocardial infarction. As I said, that ROC curve does build in this concept of discrimination. When you see something called a C-statistic, it is the same thing as the area under the ROC curve. This quote from Vasan, from that circulation paper I noted, states that the C-statistic is the probability that in two randomly paired individuals, one with and one without the disease, a given test identifies the one who has the disease. And this is averaged across all possible random pairs. This specific C-statistic is a marker of discrimination. And those curves, ROC curves, closer to the top left, have a greater C-statistic. They have a greater area under the ROC curve, which corresponds to the ability of that given biomarker or that given model to discriminate the different conditions. Now, what's really important here is that in order for you to build on what we already know, age, sex, for example, blood pressure for cardiovascular disease, you really need a biomarker that has a large effect size with the great separation between cases and individuals without the disease or without the case to have an improvement in that C-statistic. There's been an emerging literature that has discussed more sensitive implementations of this, such as the Integrated Discrimination Index or the IDI, and those are possible. I won't discuss those here. This figure that you can see here is from this journal, specifically looking at clinical variables in the green, best model of microRNA, and the composite model in the red. You can see an improvement as you layer on different covariates in the discriminative ability of these models for the outcome. Net Reclassification Index. This is a metric to quantify how risk changes. And I really would point individuals to this wonderful slide presentation that discusses some of the basics of Net Reclassification Index, or NRI. The idea of NRI is to try to understand how a given biomarker or model will reclassify individuals across the predicted, whether they have an event or whether they don't have the event. So the net reclassification index is the sum of two different probabilities. First, the probability that this given model or biomarker reclassifies an individual to forecasting an event, plus the probability that it down reclassifies an individual who would not have the event. This can be done in the context of a logistic model or a survival model, so time to event, or a binary event, non-event. There are some important ideas with an NRI that need to be mentioned. This concept is a very complicated one, but suffice to say that you have to have a model that accurately reflects the risk of an event in a population. This is a concept called calibration, which I'm not covering here, but it is a very important concept in model building. Whether you classify an individual after adding in this new RNA-based biomarker to predicting that they have an event or predicting they don't have an event really depends on what your cutoff of risk is. If you take the risk from 10% at 1 year to 20% at 1 year and your cutoff is 15%, then you've reclassified them to having an event. Whereas if your event threshold was 25%, you wouldn't reclassify the individual. So it really does depend. And there are threshold-free or category-free implementations of NRI that are frequently used when those specific thresholds aren't known. One of the most important parts of this NRI is there is similar price to upward classifying and downward reclassifying individuals. In an event that you really want to detect, you would pay a higher price to know if an individual is going to have that event. Perhaps the price of doing additional testing and following them in a clinic more would be worth it in terms of those individuals who then don't develop the event. So those events we really would like to detect and forecast and prevent, we put more of a premium to identifying people a priori who might develop the event. And so these implementations of NRI don't take that into account. Certainly, NRI should be interpreted with other predictive measures. What is the fit of a given model? What is its discrimination and association of the given biomarker? And very importantly, what population are you trying to study? Because that's, again, a very important aspect, as we discussed initially, that influences the utility of a given biomarker in a population. Some take-home points specific to RNAs and EVs. I want to walk away from here with the idea that the pre-analytical concerns are really very relevant. The ERCC has done pretty seminal work in this area in collaboration with international investigators. One of the main sources of variability is the RNA extraction across groups. This is a Cell paper published from the consortium, which describes some of the sources of variability. Things that you have to take into account: what kit is being used, when is the RNA being extracted relative to when it's collected. Again, sample types. Are you talking about from EVs, from tissue, or from plasma and serum, where some of the input RNAs may be lower? Sample handling is very important. Time on the benchtop, in terms of how long and at what temperature are you keeping the samples, and how might that affect the distribution of vesicles? How might that affect the RNAs? The number of freeze thaws. And then, of course, one of the issues in RNA sequencing from low input samples is the detectability. How do you deal with RNAs that are only rarely detectable? Perhaps they are of higher effect size, but dealing with them statistically and thinking about them in the context of developing a biomarker assay for validation is complex. The second big issue I want everyone to walk away with is that any biomarkers or panels of biomarkers that you think about really should demonstrate significant effect sizes and the ability to place individuals in one category versus another, whether we're discussing reclassification or discrimination. These are important metrics beyond just showing that a biomarker is associated with the condition. You need to really have something that's clinically useful. Thank you.